So I'm happy to introduce Beth Sylvia. Beth came to us and is graciously volunteering her time. She's a retired pharmacist, and I like to read her credentials so that I don't mess them up. Beth attended the University of Connecticut School of Pharmacy. She also attended Clark University for her MBA, and she's board certified in geriatric pharmacy. She holds licenses in Maine and Massachusetts and has 37 years of career experience. And we luckily have her to help us out.
Thank you, Simone. So I've titled this Solving Medication Puzzles. That sounds a lot more interesting than saying, let's ask your pharmacist, which is what we commonly hear. When I talk about solving medication puzzles, why is that important? Well, like it or not, medications are pretty much what keep us going once we get to a certain age. In the old days, I tell the story, and Simone's heard this one, but in the old days, we didn't live to be a ripe old age, right? We generally got eaten by a dinosaur somewhere in our 20s, maybe if we were lucky. And so there wasn't a need so much for medications. But now people live well into their 80s, 90s, 100s. Yet part of that is due to the fact that we're able to take medications. So that's what I'm here to kind of help us through. I'd be happy to assist anyone on the islands that thinks that they need some help, or perhaps knows of someone who needs some help, but they may not know that they need help. So I think you'll find some interesting caveats, and I think at least a couple of points in this will resonate. We'll keep it fun, and then if you have any questions at the end, I'm happy to answer them. And Simone and I will work moving forward to see how to best get and serve your individual needs. So how to solve the puzzle. And some of you may be thinking, okay, who is this lady? And Simone, thank you for the introduction. The way you solve the puzzle first is with passion. And I sent out, and we can provide it to anyone who would like it, but a card that I have that talks about why it is I do what I do. Because many people say to me, geez, we've not met anybody like you. And I say, yeah, I get that a lot. My last job, I had a badge ID that would give you access to different places. And I went from everywhere, the emergency room to the ICUs, not often into the surgery suites, but I did sometimes have to go into the surgery suites. And every time you're granted access, it's recorded, and badges only allow you so much access. And I had to get different accesses. And the guy said, well, who did what you did before? And I said, nobody. And well, who's going to do it after you leave? And I said, well, hopefully somebody. But he said, well, geez, we've never seen this access before. And that's because medications go across many fields and many caveats of medicine. So when I was a little girl, my grandmother was on a lot of medications. Every time they changed her medication, no one understood why. And that bothered me. And I said, well, I'm going to go to school and find out why that is. And so I was fortunate enough to attend the University of Connecticut Huskies. I went there for 5 years, and I had three professors who were very instrumental in acclimating me to business, to geriatrics, and to compounding. With that, as I was graduating, I realized, I don't think I want to be the traditional pharmacist, which I think happens. Sometimes throughout your career, you're like, ooh, do I really want to do this? And so I looked at my skill set and I said, what else can I do? And I went to work for the pharmaceutical industry. I actually was fortunate enough to work for 2 different pharmaceutical companies. And that provided a lot of business acumen. And New England was my region. My teams in Maine were always my favorite teams. And they said, that I needed to move to Maine. So I got here as soon as I could, but I had kids to get through college first. So the other piece is teamwork. As we're solving these puzzles, it requires teamwork. And by that, I mean, sometimes it's the patient and me. Oftentimes we involve a family member or another professional like Simone, or someone who might work in one of the homes. Sometimes it's another pharmacist, but you need teamwork when you are solving these puzzles. And then you need trust. And so the reason I talk about why it is I do what I do, my educational background and my experience, is so that moving forward, if we're going to work together, you have trust and okay, who is this lady? Now I understand where she came from, and so let's move forward. So that kind of gives you a background on how we go about solving these puzzles. So the medication that you're taking could be causing you distress. And so you may be thinking, okay, what does she mean by that? So you'll often hear people say as they get older that I'm cold. Well, being cold oftentimes is a result of medications, particularly beta blockers that you take for regulating your heart or high blood pressure, notoriously cause people to be cold. Tired. Sometimes people are very tired in the morning and they don't understand that. They've just woken up. Well, why am I a half hour after I've had breakfast and taken my medications? Why am I tired? Tiredness is very often a side effect. Lightheadedness. Sometimes when folks are given too much of a medication, and particularly when they stand up, they'll feel lightheaded. That's an example of a common a side effect from medications. Bruising. If people have taken aspirin or they're taking blood thinners, bruising is very common, and it can be pretty distinctive. And then lastly, some of the other distress, and this picture kind of reminds me of Douglas, but with the hands folded and the glasses, and saying, he's meditating and he's saying, what do I need? What do I need to do here? Maybe there's a question that someone's has and they don't know how to go about asking that. Those are some aspects of medication that can cause distress. This is a fun one. Sometimes it's cost. I worked with a client today in regard to her Medicare and making sure that she was able to review the medication plans and find the one that's best for her for this coming year. She's had some examples of generics being more expensive than what we call trade name drugs. And that's just because of the particular formulary of the plan that she's currently using. But that happens. You typically think, because for years they were advertised as being less expensive, so you typically think that a generic is going to be less expensive. It's not always less expensive. Sometimes it's better to pay cash and have a pharmacy apply what they call a good RX card, which is a discount card, and that can help out. If someone doesn't have Medicare and has private insurance, many of them have coupons, and it will drop a copay from $40 or $50 down to $10 or sometimes nothing at all. There are also manufacturer assistance programs. So if someone's on a limited income and they are required to take an expensive medication, oftentimes we can fill out paperwork through the manufacturer if it's a non-generically available product and have that provided to them free of cost. So those are some of the examples of where cost might be bothering someone or preventing them even from getting their medication. Okay, so now this is kind of fun. It's an example of cost, and we're going to call the medication Pizzazz, and this is a quiz. So with this Pizzazz medication, one of them costs $20 and one of them costs $140. So you can look at that and say, geez, which one looks like it's 100? Why would that be? All of these formulations, the pink tablets, the purple tablets, the yellow tablets, and then the capsules that kind of look like fish oil, they're all Pizzazz. And that's confusing in and of itself, right? Particularly if you've always taken Pizzazz and you've gotten the pink tablet and you come home from the pharmacy and you don't look when you're there, but you open it up when you get home and it's purple. And you're like, oh, geez, did I get the right thing? And okay, how come I didn't notice this at the time, but why is it $10 more? So again, this goes back to formularies. It also goes back to there's more than one manufacturer of many medications. And so while one manufacturer might make Pizzazz pink, another manufacturer is going to make Pizzazz purple. And in the days when I was training, so if your tablet shape or your tablet color changed, we would put a sticker on the vial. Well, that doesn't always happen. People are busy, they forget, it falls off. And so these are good questions to ask to say, okay, Why is the tablet formulation of this $20 while the capsule formulation is $140? And in this particular example that I had with a client, it was because the pizzazz was on formulary through their health plan, and that was the $140 copay. So the pharmacy ran a test claim for the tablet at cash and then applied the GoodRx card, and that brought it down to $20. Now, the confusing part was when they got the pizzazz tablet, the first time it was pink, and the second time they got it, it was purple. So they thought they had gotten the wrong medication. They hadn't, but they thought they had. And why wouldn't you? Because it looks completely different. So that's an example of how cost combined with formulation and color can cause people distress. When it comes to Medicare, through Eastern Area Agency on Aging, they have counselors, which they call SHIP counselors, and it stands for the Maine State Health Insurance Assistance Program. It's a mouthful. But these counselors can help you with Medicare plans, but they can so the whole plan, like the medical component, but they can also help you with the drug component. Where I used to work, they would set up appointments during what we call open enrollment, which is happening now. I think it was October 6th or October. It was like the first week in October. It goes through, I believe, December 7th. In the state of Maine, they don't set up appointments during that time, but they are available for phone calls and questions. And there is a website that you can go to, the one that I went to today, medicare.gov, and you can compare different plans. And the important piece in all of this is your zip code. So where you live matters. Because different plans offer different services to different geographies. And income is important. Well, it plays a role too. So the less income that you have, the more assistance that is available. So all of that information can be gone through with a SHIP counselor. And I bring it up because the counselors are paid through the Department of Elderly Services. So they're not paid for by an insurance company. So you are getting unbiased information. You are getting counsel that's in your best interest and not in the best interest of the insurer. So that's important to know. So that's a little bit of a solution when it comes to the cost of medications. Okay, are you taking your medication correctly? So this is fun. I'm going to first talk you through, before I go to the next example, I'm going to first talk you through my own example. And that is, I had, unfortunately, a detached retina about a year ago. And so after I had the surgery, they give you eye drops. Well, on a good day, it's not easy to administer an eye drop, and certainly not after you've lost sight in one eye. So my husband did have to help me initially with it. But there were 4 different eye drops, and you had to administer them 4 times a day. And when I was leaving the surgery, they're kind of moving you along because, believe it or not, there are a lot of people who detach retinas. And so, they're trying to get through the different patients. And so they said, wait about a minute or so, in between the eye drops so that they'll be absorbed before you administer the next one. However, when I went back for I think it was a 1-week follow-up, they said, oh no, well, you're doing everything right, except we'd like you to wait 5 minutes between each eye drop. So, there are 4 eye drops with 5 minutes in between each eye drop 4 times a day. So if you do the math, I was spending over an hour a day administering eye drops. So, and here I am, a pharmacist. I thought a minute, how long does it take to absorb? You can kind of taste it. It's a little bitter, kind of, because, your eye, everything kind of tracks. So you feel in the back of your throat. So that should have been my clue right there. Like if I, maybe you should wait a little bit longer about that. But anyway, all went well, but 4 different eye drops, 5 minutes in between, 4 times a day. And let me think about that. I think it was a month, right? And then after that, they start to wean you off. But geez Louise. Okay. So that was my example. Now, this next one is kind of fun. The prescription says take 150 milligrams of metoprolol, which is a pretty common medication, per day. The pharmacy gives you 50 milligram tablets. What do you do? So in example A, this person took 3 tablets in the morning. It looks like I'm looking at, yeah, it does say morning. I thought I had a typo there. In example B, this person takes 3 tablets at night. Okay. In example C, this person takes 1 tablet in the morning and 2 tablets at night. And in example D, this person takes 1 tablet 3 times per day. So which is correct? Well,
poorly written prescription.
What's that?
It's a poorly written prescription.
Exactly. Because in the old days you had QD, you had QOD, but what the prescription said is 150 milligrams per day. So it would indicate if you're in the business. If you're not in the business, you have no clue. So all of these answers would be right. But they did want the doctor did want the patient to take 3 tablets all at once. Now, what's up for discussion, since it's metoprolol is one of those drugs that is notorious for making people drowsy. So many people take it at night because it helps them fall asleep. However, it starts at like 12.5 milligrams. A common dosage is like 25 or 50. For someone who was naive to this medication, which this person was, to go from 0 to 150, that was a lot. And so their heart rate was going down really low at night. They were tired. They ended up going to a specialist in another city, and they cut them back from 150 to 100. And then they were going to see if they could cut them back further. The other piece with this is what the client or the patient wouldn't know is generally when you're starting medication, you go low and you go slow. So you would start at 50 and see how they do, and then maybe go to 100 and see how they do. In this case, it was for AFib, atrial fibrillation. I can understand giving them a lot in the hospital setting until you have them stabilized. But 150 milligram all at once to go home with is a lot. I have a friend who's a transplant patient, and she appears to be a rapid. So that's the other thing, is everyone metabolizes things differently, and it has to do with age sometimes, but a lot of it has to do with genetic makeup. And so she's a little bit of a thing, but she can take a high dose of metoprolol and she just keeps buzzing along. I don't know how she does it, but the patient in this example was a man in his 70s and, about 6 feet tall and, over 150 pounds, and it really affected him. So it's hard to predict. You would assume the little person is going to be, all of a sudden you see her and boom, she passes out. No, not in this case. He was more apt to pass out than my friend was. So that was a kind of a fun one for how you should take it. I talk about over-the-counter medications, and those are medications that don't require a prescription. An example is first aid creams, and I say creams. There are ointments there. In general, though, when it comes to putting any kind of medication on the skin, you like it to be water soluble, unless there's a specific reason not to have it be water soluble. So creams are generally water soluble. Ointments tend to be oil based, and when you get into oil based, you run a risk of having more chance of a microorganism getting in there. And so creams just are easier. They absorb quickly. They're less greasy. All of that. eye drops I used as an example, but over-the-counter eye drops, you have to be careful, particularly, one of the notorious ones was Visine. It constricts, so it gets rid of the redness in your eyes. However, abuse of that can cause harm. Eye drops are another example. Cough and cold medication. Recently, it came I guess it was the FDA deemed that phenylephrine is not really effective, which we kind of knew. Those of us who had ever A, taken it, or B, were familiar, it really didn't do too much. They would swear up and down it did. No, it didn't. But there's another cold medication called pseudoephedrine. And pseudoephedrine is the one that when you go to the pharmacy, and you have to ask for it now because it's behind the pharmacy, and you have to give them your license and you have to sign away your life to get a little package of pseudoephedrine. Well, the reason is that's was used for, methamphetamine labs. Now, as I said to Simone in this example, you would think like if someone's coming along with a shopping cart full of it, that would be more of an indication than, someone with a runny nose that's got a packet. But be that as it may, that's what the government decided to do. However, when you think about this, and again, you don't deal with it every day, phenylephrine and pseudoephedrine kind of sound similar. And so that's why OTCs can be confusing. And there's a big difference between phenylephrine and pseudoephedrine. Pseudoephedrine is a decongestant, works very well, but if you take a lot of it, it can make you pretty hyper, just before you go to sleep, as opposed to phenylephrine, which you could take and it probably wouldn't affect you. Herbal medications say St. John's wort. People talk about vitamin C. For the most part, vitamin C is not going to hurt you. St. John's wort can interfere with a lot of things. Turmeric, there are a number of herbal remedies which, when used appropriately, can be great, but can also interact with medications. And then the last one is preparations for constipation. They're not all created equal. So everyone thinks, well, not everyone, but in general, people think, okay, I'll take this and it's going to solve my constipation issues. But there are stimulants that increase motility. There are softeners, and then there are fiber to kind of bring more water in. So not all constipation remedies are created equal. And we see them used quite often in the elderly because as you age, you tend to drink less, you tend to be less active, your motility tends to be slower. And so that's why we see so much. And some of the drugs you take can be constipating. So that's why we see so much constipation in the elderly. When it comes to pain relievers, should I take Advil, or should I take aspirin, or should I take acetaminophen? They all start with A, right? So what could be the harm? Well, with Advil, there's Motrin, there's ibuprofen. They're all the same thing. But how would anyone know that, right? Unless that's three names to keep straight. In addition, there's Aleve, which is naproxen. So Advil, Motrin are both ibuprofen. Aleve is naproxen. They're all in the same class, but different medications. Aspirin, which was around at the beginning, was one of the first medications ever. Nowadays, if it had gone in front of the FDA, probably would not have been approved because it causes so much stomach upset and ulceration. So the recommendations have recently changed. Oftentimes you would see folks taking a baby aspirin, 81 milligrams of aspirin as a blood thinner. Well, they've redone those recommendations, and there's a small group of folks that they do recommend it for if they're at high risk, say diabetic, have a cardiac profile. But other than that, they don't recommend it because, again, it's benefit versus risk. And so many people were getting ulcers and stomach distress from aspirin that they just don't recommend it anymore. And then Tylenol or acetaminophen, you think, oh, okay, I'm going to take a Tylenol. Well, which one are you going to take? Because it comes 325, it comes 500, and it comes 650. So 325 is considered Tylenol, 500 is considered extra strength Tylenol, and 650 is considered arthritis strength Tylenol. And the recommendation on Tylenol is 4 grams per day or less. So when someone says to me, how many Tylenol should I take? It depends. So if you have the 325s at home, now you got to get out the calculator to see how many it takes to get to 4 grams. So it can be kind of confusing. One of my favorites when it comes to over-the-counter medications, and it doesn't even have to be over-the-counter medications, is, you're not feeling well, so you bring it up to your neighbor and they say, I've got just the thing. This is what I took. Try this. Okay, don't ever do that. Really bad idea. Because oftentimes they don't know what it is. If they have some left over, you wonder if it was a prescription, if they took it appropriately to begin with, but it's just not a bad idea. But we've all done this before. My parents were famous for this. They had a daughter who went to pharmacy school. Free advice, right? No. Why not ask the lady next door that works in the bank? Because she would know better. So, but we all do this, right? Bad idea. And then lastly, what do you do with medications when they get old and they are or could be expiring? I get that a lot. Is this still effective? And usually for about a year, 6 months to a year, you'll be okay. But then after that, the efficacy is much less. So when you do have an old medication that you need proper disposal, I have the cross as do this as opposed to, oh, it didn't pop up. Bummer. I don't know what happened to my slide here. Anyway, not this was a picture of a part of a toilet with a ducky on top, and that is don't flush your medications. People have for years. It's not a good idea. We have enough hormones and things in our water supply. We are fortunate on our peninsula here that Blue Hill Hospital has a box now where you can, and it's right inside the ER, so you can bring in your meds, no questions asked, completely confidential. They have bags, you put everything into the bag and you put it in the box and it will be properly disposed of. Sometimes police stations will have that, or fire stations. Pharmacies do, in different parts of the country, pharmacies do, but overall they don't want the liability of bringing back expired meds. So if someone has that question or that issue, we can help you out with that. We can, being a pharmacist, I can transport medications. Simone can. So we can, check into helping people dispose of meds. When it comes to disposal of meds, one of the things I talk about with clients too is if anyone's ever had surgery and been prescribed oxycodone or any of the controlled substances, first of all, you want to kind of keep that quiet because there's been a lot of instances over the years of grandmoms getting their drug cabinets raided, people knowing that someone's come home from surgery and could have controlled substances and hurting them to get to the meds. Because if any of you have ever been involved with people who have become addicted to medications, it's a real thing, and they will stop at nothing because it's such a tug, it's such an addiction. So we always say, whenever you're done with it, if you don't use it at all, get it properly disposed of. Try, keep it kind of quiet on if you have them in your home, and you just want to move them out as soon as possible. One of my favorite things to do, and it was not always, but is to look at people's medication lists. And the reason is you can have duplications in there without realizing it. For instance, if you come home from the hospital, whatever you're taking for medications may not be available on the hospital formulary. And so they'll substitute in, they call it therapeutic substitution. They will substitute in a medication. So for instance, I use the example of Lipitor, Torvastatin, and Simvastatin. If you were taking Simvastatin, but they gave you a Torvastatin on your discharge paperwork, sometimes it doesn't get caught. And, you may, and sometimes they'll even do discharge and maybe take two statins and not know it. Same thing happens with inhalers. Sometimes if someone's taking Advair, when you go into the hospital, they have Symbicort. And so that may not get reconciled when you go home. And the next thing you know, you've got two inhalers, and it says in your discharge paperwork to take the Symbicort, but you had the Advair at home and no one said not to take it. And so before you know it, you're doubling up. There may be interactions. Maybe they've started a new medication. In regard to both of this, duplications and interactions, if you're seeing more than one physician, or if you have seen more than one physician over the course of a year or a few months or whatever it might be a cardiologist, a gastroenterologist, and a primary care. If those prescriptions came in at different times, the pharmacy may not have record of all that. And so you could have an interaction that you don't know about. Again, you could have a duplication that you don't know about. So it's good to look at that. Devices, I have a couple of examples. Here's a discus device. That's one type of inhaler. And then we have the traditional inhaler, which is not easy to use. It's you think that, okay, so they say to take a deep breath and let it go, and then try and push down on the inhaler while you're breathing in again. It takes coordination, and it's really hard to do. People spray it like hairspray. So it doesn't hurt to go through these lists and to see if people can figure A, know how to use it, and B, so again, when we talked about some of these inhalers, they want you to rinse and spit afterward because they have steroids in them. Well, sometimes that gets conveyed, sometimes it doesn't. Sometimes people rinse and then they swallow it. Well, you don't want to be swallowing all that steroid. So it's a good idea to go through some of this. No two puzzles are ever the same. Everyone is different. Even if you have one question today, something can change with your health and you'll have a different question. And so if there's any way that we can help, we're more than happy. I'm more than happy to do that. I work very closely with, we'll be working very closely with the Sunbeam and Maine Seacoast Trust and Simone and Douglas. So anything we can do to help, we will. And with that, I'll go back to my intro of solving medication puzzles. And if there's any way I can help assist you in doing that, I'm more than happy to do so.
Beth, do you see this a lot? I'm always surprised when I see patients who have things like, and Tom, this is, I'm sure you guys see this too, but I'm always amazed when patients are on things like amiodarone or just big meds like that, and they feel awful and they have no idea why they're feeling bad, and it just seems so obvious. But I feel like there's so many patients that have medications and they feel terrible and just don't, it just seems like it would be such a short conversation.
Yeah, and I do see it, and I see it personally myself. I have doctors that put me on medication and I feel like crap, and I go back to them and then say, I can't take this drug. And I think it's much more common than the industry lets on to be, that there are a lot of side effects. Many of them are minor, but they can, especially when you put multiple drugs together, it's not unusual to have things that are really debilitating.
Yeah.
You know, I was taking some of the, I guess it was Lipitor way back when, and after about a month, I couldn't walk anymore. So I stopped it and quickly regained my ability to walk. And then I restarted again just as a challenge. And sure enough, very clearly that was the cause. But, you know, it's hard to tell sometimes.
Yeah, that's true. And that's a fairly common one. The other is, you know, sometimes when people take Synthroid or levothyroxine, and next thing they know, their blood glucose levels are sneaking up. You know, every action has a reaction, right? That's the rule number one in physics. And so it's true. And that's why we get into risk or benefit versus risk. Even when it comes to people's care. So that's why we talk about this teamwork approach is, you know, if you can spell out to them what it is that might be, we call it a condition, but what it is that's wrong with them, and then what the progress forward or what the path forward might look like, and then let them make the choice. Because you know what, some people do not want to have the side effects of the drugs. And that, you know what, that's okay. That's their decision. So I think Tom would agree with this. We're not here to force folks. If they have chosen to take these meds, and many people do, we can kind of talk through the pro and the con, the benefit versus the risk. But you will bump into people who say, nope, I'm just going to roll the dice. And you know what? Sometimes they roll the dice and do really well. Same thing with trying to get assistance. So, you know, we've all seen what's happened after COVID. A lot of health professionals have retired, moved on, whatever you know, there's been many scenarios. So there's a shortage. And so if you have something really wrong, many of us will oftentimes say, okay, you know, you may want to consider Portland, or you may want to consider Boston, or you may want to consider New York, particularly if it's a summer person, that's where they're from. But you know what? If they don't want to travel that distance, that's okay. You just have to know there is some risk with where we choose to live, because we're not in a medical mecca. You know, so if something happens, if you develop a disease state that requires more intervention, if that's what you choose, you may be looking at a lifestyle change. But that's okay. You know, some people, you know, it has to be the person's decision, or else you won't get by and you can't help them.